Hello, and welcome back to another episode of the 2020 Podcast, Canada's #1 optometry podcast. I am your host, Dr. Harbir Sayan. Thank you, as always, guys, for taking the time to join me here to learn and to grow. I'm always so grateful for all the support. As always, I have a huge request right off the top. If you get some value from this episode, please do share it. Send a link to a friend. Send a text message. Put it up on LinkedIn. Put a screenshot up on Instagram. Whatever you do, please let people know. Especially because this episode is a very special episode, episode 213. I'm not usually sharing the episode number with you guys, but the reason I'm doing that today is because this is a milestone episode. It is a landmark episode for the 2020 podcast. This is the first ever COPE approved episode of the 2020 podcast. That's correct. You heard me right. Just by listening to this episode, you can get yourself 1 hour of COPE accredited CE. So that is what makes this episode so special. And the reason we're able to do this is because of a brand new partnership and collaboration with my alma mater, the New England College of Optometry. I'm so grateful to NECO, in particular, Dr. Gary Chu there, for helping me put this together. So this episode is going to be the first of hopefully many over the coming months where I'm going to share one of my COPE approved lectures with you. And you'll be able to, as I said, as you listen to this, get yourself 1 hour of COPE approved CE. A little bit of housekeeping. You can't just listen to it and then write down that you listened to it. There's one extra step. You're going to need to go to the NECO website and register there and take a quiz, and they'll get you a certificate to show that you listened to this lecture and that you took the quiz, and that you can get CE credit. The link is going to be in the show notes, but in general, if you go to necoce.org, NECOCE.org, you'll find a whole bunch of webinars there that you can get CE credit from. And this lecture, this podcast episode will be there as well. But specifically, go to the link in the show notes once you're done and click on that link, register there, and you'll get the CE for free. This episode, there'll be other CE lectures there that you could pay for, but this one in particular will be for free. So you go there, you click the link, take the quiz, and you'll get that certificate. Thank you. And of course, if you know anybody who's looking for an hour of CE and they want to get it in the easiest, most digestible way possible, send them this podcast. It's available on Apple, Spotify, all your usual listening apps, and on YouTube. I would encourage you to go on YouTube because I am going to be sharing my slides there, but the slides will also be available on the NECO website. All right. So here we go. We're going to dive in to this lecture, which is my lecture on the business of myopia. And when I say the business of myopia, yes, we're going to be talking about some dollars and cents in there, but really it's about how are you going to set up a myopia practice in your clinic. It's not just simply, I'm going to prescribe this lens, this contact lens or eye drop or whatever it is. We really need to be able to set the groundwork and, get our staff trained and all these things and make sure we got all the right things in place so that our clinic will succeed, our patients will get the best care, and everybody wins. All right. So the business of myopia, setting up your patients and your practice for success. Let's get some of these out of the way, some disclosures, and let's go down what our outline is going to be. What is our journey through this hour or so of lecture material? We're going to start with the patient journey. This is actually going to then inform all of the other aspects of this lecture. We're going to go through all the steps of the patient journey and where we can implement certain tactics, certain strategies that are going to help us succeed in myopia management. We're going to talk about what types of investments are required, what types of equipment we want to buy, do we need it, when do we need it. We'll talk about the different treatment options. We're not going to speak too much about clinical care. I'm not going to tell you too much about how I diagnose or how I prescribe, but there'll be a little bit of that. But ultimately, we'll just go over what the available options are, especially exciting now because in the US, you have the spectacle lens option as well as we do in Canada. We'll go over some protocols for staff and for doctors. Documentation and communication is vital in these types of any type of specialty care. Then we'll go over some cost, fees, and metrics. We'll talk a little bit about marketing and a little bit about industry relationships and how important those will become as we want to lean into any specialty in our practice. So before we jump in, the question I want to ask you is, and of course, since there's not a live audience here, it's a bit of a rhetorical question, is myopia management the right specialty for you? These are questions that you want to ask. This is a question you want to ask yourself no matter what specialty you're going into. You can say, is insert any specialty the right specialty for you? And there's really a few questions you want to ask yourself to determine if it is. Number one is, are you passionate about it? Are you talking about it with everybody? Are you okay talking about it off hours when you're at a dinner party? Are you okay talking about it with every patient that comes in and every parent that comes in? Do you have the existing patient base? This is a big one. Whether you're doing dry eye or VT or myopia, if there are already patients in the seat in your exam chair, it makes your life much easier. You don't have to start by doing external marketing. We'll need to do that at some point, but you can just start with the person that's right in front of you right now. And then do you have the time and space to invest in this specialty? Some specialties will require more space, some will be less, but all of them will require time, and of course some of them will require bigger financial investment as well. Do you have the time and space? We can't just say, again, I'm going to prescribe this lens and not actually develop the program within our practice. We really got to spend the time to build it out. So if you say yes to all of these three things, then I think myopia management could be the right specialty for you. But even then, before we go into diving into myopia management, we have to make sure that we've done one other very important thing. And that is, we need to flip a switch in our mind about how we think about myopia. Do we think of myopia as simply a refractive condition? In that case, we're just correcting myopia. Or do we think about myopia as an actual ocular disease that then has a refractive component? And I think that's the mindset we need to be in if we're really going to be treating myopia, if we're really going to build a myopia practice. And then, of course, the term that comes to mind is myopia control. But I think we need to go a step beyond myopia control into myopia management, hence the title of the lecture, of course. So what's the difference between myopia control and myopia management? Myopia control, for me, is simply prescribing a medication, prescribing a lens. Myopia management is the entire oversight of the entire patient journey and their entire lifespan, their entire ocular health journey. So that means before they're even myopic, to when they become myopic, to when we start myopia control, to when the myopia has hopefully stabilized and we still need to monitor, then we need to change up the plan. But then understanding that because the patient's myopic, they have a higher risk for ocular diseases in the future, and now we have to manage those. This is myopia management. And of course, integrating things that are lifestyle choices, not simply prescription, but spending more time outdoors and other lifestyle choices that can help inform the patient and make better decisions. This is myopia management, and this is what we want to really think about how we're going to approach each and every myopia patient as we move forward. I like to use the analogy, and I'll use it again later, but we wouldn't start a patient on a drug and then not monitor their outcome afterwards, right? A simple example is putting somebody on an IOP lowering medication and then not checking their IOP or not checking their visual field or their OCT. That is glaucoma management, right? We need to be able to do have the same kind of approach for myopia if we understand that it's an ocular disease and not just a refractive condition. So let's jump in. Step one is really hashing out, diving in to the patient journey. If you are really interested in learning a lot more about how to elevate your patient journey, it's a really big topic. And I did a whole discussion, one whole podcast on this with Dr. Wes McCann, who's kind of the master at this, having as many clinics as he does. He's really refined the patient journey in each of his clinics. So if you go back, I don't know when you're going to be listening to this. It could be a dozen, it could be 30 episodes back. But if you scroll down and you see an episode about patient journey with Dr. Wes McCann, I think you'll really find that really valuable. And when I had that conversation with Dr. McCann, I asked him, where does the patient journey begin? And a lot of us would maybe think the patient journey begins when the patient enters our office. But really, what Dr. McCann said in that episode, and what I think I want us to all keep in mind, is the patient journey starts before they enter the office. The patient journey begins when the patient is looking for us. The patient journey begins if they are a patient of ours, maybe they're dialing our phone number, maybe they're looking us up online and looking up a way to contact us to book their eye exam. Or if they're a brand new patient, they're searching us via social media or through our website or just straight Googling, eye doctor near me. That's where the patient journey begins. And the question is, how do they find you? How do they find you? What have you done to build your website and build your social media presence to make sure that a brand new patient will find you? And then what will they see when they end up on your website? Will they see that you are a myopia management clinic, that you specialize in this type of care, that you offer these services? When they call your office, what is the staff saying to the patient or the parent over the phone? Are they saying, yes, we can book you in for a routine eye exam? Or are they offering and mentioning a myopia exam? myopia screening? Is that something that they're saying to the parent so the parent understands that this is something that your clinic offers? The next step is when the patient does actually enter the office. Is there signage around your office that talks about myopia? Is there something in the office that indicates that you see children and that you are interested in treating myopia? What is the conversation that patients are having at the front desk with the staff? The staff, again, mentioning that you have a myopia exam, a myopia screening. Are they asking about family history? Are they asking about, does the child wear glasses? Have they had glasses before? And then we go into the pretest area. And of course, there's conversations that can be had there that would indicate that you have a myopia management program. Is again, looking at the autorefractor, looking at the lensometry. There's multiple touch points and areas where the staff can simply say, oh, your child is nearsighted. Did you know that there's ways to slow down progression of myopia? And we offer those treatment options here in our office. I mentioned the intake form here. This is something that's been really valuable for us. Of course, based on where you are, it's going to look very different. But I'm going to share with you, again, this is for those of you who are not watching. Please go onto YouTube and check out these visuals that I'll provide for you. Or, of course, if you go to the NECA website, the slides will be available there as well. But I want to share with you our intake form for one of our offices. We outline all of the fees. We're based in British Columbia in Canada. And here, the government does cover some portion of eye exams. And so we have 3 different levels of eye exams. We have level 1, which is the routine eye exam that's covered by the government. We have a level 2 eye exam, which is if you want to have wide field retinal imaging, that is level 2. And then level 3 is what we call our myopia screening. And that one includes the wide field retinal imaging. It includes axial length, topography, and a few other tests like that. So, and of course, the discussion with the doctor in the exam room about the results from these things. And then we'll print out, which we'll talk about later, a report from that myopia screening indicating the level of risk for that patient to become myopic or progress. So we have the staff will present this to the patient, the parent, at check-in. Parent needs to sign this form regardless, and the staff will say, please fill out this bottom section here and let us know if you have any questions of the level of eye exam you'd like to have for your child. And of course, almost inevitably, there will be questions. What's myopia? What's a myopia screening? What does that include? And a discussion has started. So the intake form can be a really valuable touch point for the staff to have that conversation with the parent. So now they've gone through pre-testing and they're sitting in the exam room. And I like to ask with the doctor now, right? And the doctor is doing the eye exam. And I like to ask this question in person. I'll ask you this, have a quick thought about it. How do you diagnose myopia? And it's not a trick question. All right. It's an actual question. It's not a trick question. How do you diagnose myopia? Of course, inevitably the question answers will be something like retinoscopy, refraction, autorefraction, that type of thing. And that's right. We use those tools. But ultimately, what finding do you see that then makes you say this patient is myopic? And that'll usually be a minus prescription, right? Again, not a trick question, but that is the old way of looking at myopia. That is our old way of diagnosing myopia. In that case, we are simply just looking to correct myopia. We need to learn a lot more about the patient, and we need to then write a diagnosis that is much more in depth. We wouldn't just simply say this patient has glaucoma, right? We are going to define it. It's primary open angle glaucoma. And we're going to say, is it early stage, mid stage, advanced stage? Same with macular degeneration, right? We wouldn't simply just say AMD, end of story. We are going to describe it and define it in a much more detailed way. And that's what I want us to do with myopia. Is a child, are we comfortable using the term pre-myopia, right? Is a child, or do you just simply say the child is hyperopic and leave it at that? But what if the child is plus a quarter at age 4? Is that simply hyperopic or emetropic, or is that child actually at risk of becoming a myope? What if their older brother is a -5 and this child sitting in front of you is plus a quarter? Do we simply let them go and say, okay, emetrope, see you later? Are we willing to define that as a pre-myope, a likely risk of becoming myopia, and have that discussion with the parent? These are the types of things we need to have or use to diagnose myopia in the patient. If they're a minus of 0.5 at age 6, are we okay with, are we just going to say, oh, they're just a low myope, not a big deal? Or are we going to say this child's actually high risk of progressing, high risk of becoming a high myope, high risk of ocular disease in the future. We have to document all these things. And then we have to have the conversation with the parent. And here's another opportunity for us to provide information. Uh, and what we do in our office is we provide these brochures, these pamphlets here. This is a nice image from Canva. So I designed them on Canva, but then Canva provides these images of what the pamphlet, simulation of what the pamphlet would look like. This is exactly what it looks like. And we then at the end of the exam, will hand this to the parent and say, your child is nearsighted and there are treatment options. We're going to have the child come back for a consultation, which we're going to talk about a little bit more in just a moment here. But I hand this brochure has some rough pricing on it. It has some information about the treatment options. And I give this to the parent and say, here's a chance for you to go home and, please go ahead and research these things if you like, come back with questions. But I want you to know that we offer all of these treatment options in our practice. And then we'll head up to the front desk and we'll book the consultation. And the patient will come back, and this is where we do all the relevant tests related to myopia. Now, in the case of where I've handed that brochure, we can assume that patient had come in, maybe just done a routine eye exam, but we need to do all these extra tests. But if they'd come in and done a myopia screening, the axial length, the topography, the retinal images, that all would have been done already. Now the patients are mostly coming back for the cyclo and this conversation with the parent about which treatment option are we going to initiate. And we have another handout for that. We don't use this one as much because usually parents have kind of come to a decision by this point, but if we need more visuals for the parent, I took this from my good friend, Dr. Sherman Tung. Thank you, Sherman, for letting me basically steal this design from you. So he has, because their office is really deeply entrenched in myopia management, they have all sorts of this kind of literature and these handouts. And I took this design from him. Basically, it's a full page sheet, two-sided. On the front side, we have a place for the doctor to draw and write and say, explain what is myopia, the axial elongation, maybe talk about peripheral hyperopic defocus driving the elongation of the eye. And then on the flip side, we have the 4 treatment options. Again, a space for the doctor to draw and write. How do these treatment options work? What are the pros and cons? And ultimately come to a decision with the parent on which treatment option is going to be the best for the patient. Now, we have some questions about, do we charge for this consultation or do we do it for free? And now, actually, we have both options in our practice, and both have pros and cons. And the same kind of goes with like a dry eye consultation. This is something anybody who's in the dry eye space will do, kind of have a similar approach where the patient comes in, you diagnose the dry eye, and you say, well, you got to come back for the consultation where we do the whole gamut of diagnostic tests. I think there are pros and cons, and we've done both things in the dry eye space, in the myopia space. And we've kind of done it here now where we have a dual approach, actually. We do currently have both things at the same time. And it'll depend on what the patient did or how they found us. Now, I think a free consultation is a great marketing tool. If you are trying to get new patients to come in, you can offer a free consultation. And it's worked well, especially in the case of Ortho-K. I'm going to show you in just a second what we've done with Ortho-K. If they have not had an eye exam with us, we're going to charge. If they have not had a myopia exam screening, if they're a patient who did a routine checkup, now they're coming back for a myopia screening, we'll charge for it. Often if a patient has been referred to us by another optometrist, they're new to us, we'll charge for that consultation. But through other means, for example, we did a little marketing around Ortho-K. We marketed a free Ortho-K consultation, and you can do the same thing with the myopia. If you were to do a social media thing or Google ads or something like that, and you're marketing a free myopia consultation, what we did there is we would have the patient click through and they would end up on our website, or they would go straight to this booking page. And we created a separate, as you can see on the right hand side here, the fourth one, we created a separate booking link for Ortho-K, for an Ortho-K consultation. We have our routine adult, senior, and child exams. We try to keep it as simple as possible. And then we got the Ortho-K. And that will lead to a free appointment in our office, and no charge appointment at our office. And it'll show up on our EMR, and the staff will know that the patient booked this Ortho-K consultation. They'll know when and we're going to talk a bit more about the importance of a good EMR in a moment too, but the staff will know what tests to do beforehand. And ultimately, doctor will end up in the exam room with the patient to have this discussion about myopia or Ortho-K in this particular case. So, free or paid consultation, it's really up to you. I think you may want to experiment to see which is the better option for you. At the end of the consultation, as I mentioned, we'll end up developing our plan. And at this point, we're going to go up to the front of the front of the office, and here we have actually a consent letter or an enrollment letter, and show you that in just a second. We get that patient and that parent buy-in that we're going to start this program together, and we're going to make sure we see it through. And at that front desk, then we book the follow-ups based on the doctor's schedule. Do we need to see this patient back in 6 months, 4 months, 3 months? And we make sure we book all the upcoming appointments right now, so they're in the system, and the patient and the parent know we're committed to this. Now, I want to show you this enrollment letter. These things are optional, but ultimately, if you are really leaning into a specialty like this, these little documents, they help keep everyone on the same page. Well, then this will go straight into the patient's file on the EMR. Everything's visible for us. If we ever got to pull it up, we say, look, we agreed to this, to seeing this patient back this many times. You agreed, you understood that there were these fees involved here. You understood there was a warranty period with the Ortho-K. All of these things are documented, and the parent will initial under whichever treatment option we're moving forward with. They'll initial under the program fees and the expected visits, and then acknowledgement at the bottom, and we sign. The doctor will sign, and like I said, we put this on the file. Everybody's on the same page. Really improves the buy-in and the commitment from the patient and the parent. Now, the next step of the journey. So we've done, they found us online. They came to the front desk. They talked during pre-test. They did the routine eye exam. They came back for the consultation. We have started them on the path, the myopia management journey here. We need to then do the follow-up appointments. And this is where you recheck the refraction, you do the axial length, you update the plan as needed, right? If you're at 3 months and things are still progressing, then you're at 6 months and things are still progressing, maybe we need to reevaluate. We have that discussion with the parent. Usually it takes 6 months for that treatment option to really have the effect that we want, start to see the trend on the axial length that we want to see. But if we get to 6 months, 9 months, or a year, and we're still seeing progression, it's not slowing down, then we need to maybe alter our course. Maybe we need to change to a different method of myopia management. Maybe we need to add a second treatment option. These are the conversations that we're going to have during these follow-up appointments. So that's the entire patient journey I want us to keep in mind, from when they found us online to got the diagnosis to the follow-up appointments. There's all these important touch points along the way. And I've already showed you some documentation, some literature, and some information that we could provide to the parent, to the patient. But we're going to talk a little bit more about some other information that we could provide along the way, going back and revisiting some of those important touch points along the way for the patient journey. So one of the first questions that comes up when we're talking about any specialty is like, oh, which equipment should I buy? Do I need this one or that one? Do I need to invest in the whole suite of equipment, or can I just buy one thing? I like to make sure we've really outlined the patient journey or the protocols or the algorithm that we need to have in place first, so you understand what's actually involved through the entire pathway, and then you can understand, do you need equipment, and where does the equipment fit along that patient journey? So the most important or the most obvious piece of equipment with myopia management is a biometer for measuring axial length. Now, do you need a biometer right away? The answer is no. Do you need a biometer at some point? Yes, absolutely. If we want to lean into myopia management, a biometer is going to become a very, very important piece of equipment. Again, if we think about myopia as an ocular disease and not just a refractive condition, the only tool we have for really tracking the disease state is an axial length, or a biometer to measure axial length, right? So the same way you need for glaucoma, you need to check IOP, you need a visual field, you need an OCT for tracking the disease state. In this case, for myopia, we need the axial length. We need to take retinal images to make sure that the retina is healthy. We need these tools to make sure we're really tracking myopia as an ocular disease and not just a refractive condition. So yes, you will need a biometer if you truly want to treat myopia, but at some point, you don't need it. It shouldn't be a hurdle to you beginning to treat myopia, to beginning your myopia management practice in your clinic. There are online estimator tools, axial length estimator tools, I'll show you in just a second, that can be really handy in the beginning. As we'll talk about, they're not great for tracking myopia, but great for initiating the conversation in your office. A topographer is not mandatory, but can be a really valuable tool if you're going to get into Ortho-K. The topography guided Ortho-K is an amazing option, a really streamlined, low bar to entry for topography guided Ortho-K. It's a really easy treatment option to bring into your office, and really easy treatment option to implement, especially if you have a topographer. So I would highly recommend at some point along the journey, if you don't already have a topographer, get yourself a good one. And we'll talk a little bit more about what the steps are involved in topography guided ortho K and why it's so valuable. Other investments you want to think about are really like little things. You got to create accounts. You might need to get some training done, certification for certain lenses. If you do start doing ortho K, you're going to want plungers and solutions and all these things to make sure you're all set there. And of course, training that's involved. Are your staff going to do the ortho K, insertion removal training and things like that? So those are things you want to get in your mind, at least in the beginning, understanding there's going to be steps like that involved. But ultimately, the big one is a biometer for axial length at some point. So I talked about online estimator tools. CooperVision has one, and there's another one out there called Ocumetra. Just going to show you just really briefly what it looks like here. So again, if you're listening, you can go on YouTube. I'll have all the slides here. I'm showing all the slides. Here's a CooperVision online estimator. Basically, you enter in the prescription, you enter in K readings, vertex distance, is it a cycloplegic refraction or not, male, female, and then age, and then it gives you an estimation like this. And again, there's a pretty large margin of error here. I think it's 0.3 millimeters or something. It's on the website. It'll kind of show you, so right? But that's why it's not maybe the best tool for tracking, but it's a great tool for starting the conversation. Because if you have a patient in front of you who's 6 years old and has a 24 millimeter eye or 24.5 or something on the estimator tool, you can safely say that that's a much longer eye than you should have at 6 years old, and have that conversation with the parent that, we're already beyond where we should be. It's time for us to implement some sort of treatment and help get that conversation off the ground. Here's the Ocumetra tool. I think the Ocumetra sort of margin for error is pretty much the same as the CooperVision tool. Ocumetra has other resources and tools in their program that are quite useful if you're starting out and you want to provide resources to the patient, to the parent, and send emails and send reports and things like that. We don't use Ocumetra. I'm not promoting it, but I've seen the program and it's quite useful for anybody who's especially starting out, but even if you're quite leaning into myopia management already. So those are the investments I think that would be useful. Again, biometer kind of being the key one. I think you should start your myopia management clinic by implementing a lot of these other things and having the conversations and starting to offer some of these solutions that we're about to talk about. And then as you see that growing in your practice and the excitement building and the confidence building in your practice, then you can really think about making that investment. Axial length biometer is going to cost a reasonable amount of money. It's going to be different pricing depending on what type of machine you're getting. There's combo tools that'll do multiple things. There's standalone biometers. And so you'll really want to see what fits best in your practice. So step number 3 is offering some sort of solutions if you don't already. And the number one thing I want to say here, depending on where you are in your journey, if you're brand new to myopia management or you're just dipping your toes in, the number one thing I want to say is that you should start small. Start small by offering one solution, one treatment option that is going to be the most comfortable for you, the easiest for you to implement, and build confidence there. And then build the program around it and all the other things that need to be there, the information, the brochures, the pamphlets, the training for the staff. And when you see that it's working, then you can easily add the next one or the third one. They'll just kind of integrate easily into your program that you've already built. So pick one treatment that you find is going to be the easiest for you. I think, in my opinion, spectacle lenses are probably the easiest option. And given that now that's available in the US, anybody who's listening in the States, now you have this spectacle option. It's the easiest to understand. We'll talk a bit more about it as well in just a second. But let's say you're a really big contact lens person. That's fine. Start doing contact lenses. Or maybe you're not a big fan of any of those options and you want to start with an eye drop. Sure, atropine could be your entry point. It was my entry point because when I started 8 years ago, there were no, or maybe longer, there were no actually approved contact lenses. There were no approved spectacle lens options. And I wasn't into ortho K yet. So for me, atropine was my entry point. And that's all I did for a few years until I started to do some contact lens options and then spectacle lens options. And so that's how I would suggest it. If you haven't already leaned into anything, pick whichever one you think is the easiest. If you're already dabbling, then build some of the program around what you're doing and then add the second one or the third one. So let's go through the 4 main treatment options quickly here. Again, I don't want to spend too much time In a clinical conversation, I want to make it a bit more of a program design type of conversation. So we just need to understand how these treatments work, what their pros and cons are, so we can understand which one we want to implement first or second or third, and then how we can build a program around it. So atropine, it's an eye drop. It's easy to understand. Sometimes parents like it because they want something medicated. It can be added on as a combo to another treatment. That's kind of a nice bonus with the atropine. It's just one drop each eye at night, so prescription and dosing is very easy. Obviously, it's a medication, it's a pharmaceutical agent, so that's a downside for some people. Flip side, some people like that idea, some people don't. They don't want to medicate their children. There are potential side effects. Light sensitivity and near vision blur are kind of the two most common ones. In those cases, I always start everybody at 0.05%, everybody. And then if there are side effects, I'll reduce it to zero point zero 0.02 or 0.025. And then usually, almost always, the side effects will go down after that. Obviously, atropine doesn't correct vision. So if somebody needs glasses, they're going to need the eye drops and the glasses. And of course, it needs to be formulated in a specific sterile compounding pharmacy. So that's an important thing to keep in mind. It's not going to be as easily accessible to everybody. But that's something I'm going to talk a little bit about in our procedures later of how we overcome that a little bit. We use atropine now. I used to use it as my first line of treatment. I don't anymore. I really use it for specific cases. As I mentioned, combo treatment. I'll use it for those pre-myopes. So the child who doesn't really need glasses right now, but definitely is on the track to becoming nearsighted, or the very early myopes who, again, they see quite well, and we just need to implement some sort of treatment. When do we stop it? I usually will assess based on how stable the RX and the axial length is. If they are completely stable, then we'll take them off. Or if we're changing modality, the parent doesn't want to do eye drops anymore, we're switching them over to something else. And no matter what we're doing, no matter why we're stopping the atropine, we always need to taper. We don't stop cold turkey. If you've read any of the studies that are out there, there's enough data to show stopping cold turkey can result in a pretty big rebound. So tapering has been useful for us. And what we'll do is we'll taper the frequency of dosing. So instead of every night, we'll reduce it to every other night for a period of time, then twice a week for a period of time, and then once a week for a period of time. And then we'll have the patient back to make sure everything's still stable once we've discontinued. Now, the next option we're going to talk about, treatment option we're going to talk about, is the soft contact lenses. And in Canada, we have a couple of different brands available. Both Cooper and J&J have an option. I think in the States, it's maybe only MySight. But in any case, how we use the lens is the same. Their design is different, but how we use the lens is the same. And ultimately, contacts are great for somebody who's looking for freedom from glasses. Daily disposable is great as a modality for kids. The downside is, a lot of parents are kind of averse to having contacts on young kids. As much as we might try to convince them, there's a bit of a hurdle there. Insertion and removal can be a little tricky for some people. And of course, the main limitation for me is the lack of toric options. There are none. But, I've seen myself, and I've heard from other practitioners who prescribe a lot of soft lenses, that the lens design can absorb a fair bit of astigmatism. And in some cases, a little bit of residual astigmatism might actually not be a bad thing. And kids are usually pretty tolerant of a little bit of undercorrection anyway. So you have a little bit of flexibility, 0.75, even up to -1 in some cases, where you can get away with that uncorrected astigmatism. Okay, so the next type of contact lens option is the Ortho-K lens, of course. And for anybody who's completely new to Ortho-K, these are lenses, custom designed lenses that you wear at nighttime. And they're correcting the shape of the cornea, or changing the shape of the cornea overnight to correct the vision, and creating this peripheral blur and distortion that helps actually to help slow down the progression of myopia. So a really great option for combined treatment and vision correction. They are available in a wide range of prescriptions, but once you get above a certain, -5 sphere, -1 cil, -1.5 cil maybe, you start getting a bit more into more customized designs, and there you're going to be a bit more specialized, and you have better expertise in designing the contact lens. But you still get a pretty large range of patients who do really well in an Ortho-K lens. And we're going to talk a little bit about the topography guided system in just a second here. Downsides, cost. Cost is probably the number one thing. It's not cheap, but I think if you really present the value that Ortho-K lenses bring, most patients, most parents, I would say, really, they can see past the actual cost of the lens when they start to understand the value. And it's relatively comparable to your daily disposable myopia control lenses when you start to kind of break it down over a longer period of time. So the cost is not that much of an obstacle once we get comfortable how we talk about it. Of course, you got to wear the lenses every night to maintain the vision correction and the effect. It could take a few days or even up to a couple of weeks to fully correct the vision depending on the prescription. So you end up with this kind of gray zone where the vision's not fully corrected, but the glasses are too strong now. And so we'll find ways around that. Often we'll dispense, 5 days worth or a week's worth of soft contact lenses that the patient can wear until their vision's fully corrected with the Ortho-K. So this is something that we've really only integrated in our practice in the last few years, but it has been massive for us. It's been awesome. Patients have loved it. It's helped build so much confidence in our practice in myopia management because patients come back so happy. Our staff sees that. Our associate doctors see it. And speaking of associate doctors, getting them on board with Ortho-K has become so easy now because it's such a streamlined process with the topography guided Ortho-K. So essentially, your topographer is connected to the software that is used to design the contact lens. So we take the topography, simply click a couple of buttons, enter a bit of information, the prescription, the horizontal visible iris diameter in numbers that are all basically measured on the topographer anyway. And we upload that to the system, and bada bing, bada boom, the lenses are ordered within a matter of maybe 5 minutes. And in about a week, the lenses arrive and we start the fitting process. It's really that easy. And then all of your decision making is then guided and informed by the topographer. You do topography at each visit, and you click some buttons based on what the topography looks like. And if adjustments are needed, we upload those. And again, bada bing, bada boom, lenses arrive. So really has become a great process for us and a great option for us in myopia management. But also, even for adults, we've adult patients who were Ortho-K as well. It's been a really nice way to provide freedom for adults who don't want to wear glasses at all. Now, last but not least is the spectacle lens option. This is huge right now. I mean, I don't know when you're going to be listening to this because it could be living on NECO's website for years and years. But at this stage in 2026, the FDA has just approved a spectacle lens in the US. So it's really a big topic right now. And it's such an easy modality to prescribe. Honestly, if you're going to be prescribing, if you're really new to myopia management and you're just going to be prescribing a pair of glasses to a patient and you're not super comfortable with initiating any sort of treatment, the very least you could do is just write the name of one of these myopia management lenses on the prescription and just say, just go buy this. At least you know you're doing something small, actually not that small, but I'd love for you to do more. I'd love for you to have that patient come back and measure all these important metrics that we want to help us maintain this myopia management treatment. Okay, glasses are great because they correct vision and they also, of course, are slowing down the progression of myopia. And we'll talk a little bit about lens designs, but not too much here. The downside is, like the soft contact lenses, you got to wear them all day to really have the effect that we are hoping to have. And of course, if it's an active child, wearing a pair of glasses could kind of get in the way. In Canada, we have three myopia lens options. I just want to quickly mention them briefly here. I know in the US, there's only one right now. Hoya MyoSmart is the one that's been on the market the longest using the DIMS technology. Essilor Stellest is the one that just got approved in the US. And I think there's a 2.0 coming out pretty soon here using the HALT technology. You can see the difference in the ring design. And the third one that's coming out, it's not out yet at the time of this, the time I'm recording this, but the CooperVision MySight lens, which uses dot technology. So the Hoya and the Essilor are both using the idea there is to induce peripheral myopic defocus. They are defocusing the light, bringing it inside the retina to slow down axial elongation. Whereas the CooperVision lens is actually using this diffusion optics technology, which is reducing contrast. So a whole different approach. The theory here is reducing contrast helps to reduce axial elongation over time. So excited to see this lens option hit the market and provide another option for us to help treat our patients. The big question after all of this, the big question is, which treatment is best? So I'm going to ask you, I want you to take a second and answer this question. Write it down maybe. Which treatment is best? Is it glasses? Is it contacts? Is it atropine? Well, the answer to this question is whichever treatment the child would use. Compliance is the answer to this question. Which treatment is going to give us the best compliance? And This is the same type of conversation we'll have with other diseases and treatments as well, right? Glaucoma, for example. If the patient is just not going to use their drops, maybe we need to do SLT. And that way we've gotten that treatment, we've gotten the effect of lowering the IOP without having to trust the patient to use their eye drops. The same goes with with myopia management. Is the child going to wear their glasses? Are they going to wear contact lenses? If not, maybe atropine is the only option for this child. Or is this child extremely averse to eye drops? Maybe they'll have to wear glasses in that case. We have to decide which option is going to give us the best compliance first. And then we have to think about all the other factors involved. I do share this little grid here. It's very basic, but just to kind of give you some ideas of questions you want to ask the parent, the patient, and yourself. Is the child going to wear contacts, or are they going to use eye drops? Are they totally averse to that? Do they need complete freedom from all sorts of correction during the day, like a swimmer, for example? Does this kid need to jump in the pool 5 days a week and you don't want them to have to think about their contact lenses or their glasses? In that case, maybe ortho K is the best option. So these are the types of things you want to ask yourself, but ultimately compliance is the number one thing you want to consider when implementing any treatment. Okay, so a little recap. We went through the patient journey. We talked about which investments we want to make, which equipment we might want to buy. And then we talked about what the treatment options are. And we talked about starting small if you're brand new, but then really picking up some speed and starting to implement some of the other treatments as you build your confidence. Now, all of this is going to be almost useless, but it's not going to be effective in your practice if you don't have protocols set up. You need to have an algorithm, so to speak. If I turn this dial, this thing happens. If I press this button, this thing happens, a cascade of events. We need to have this written down and on display, or at least written somewhere where your staff and your doctors can read it and they understand what needs to happen. If you don't have a protocol, it ends up being messy. I can tell you from my own experience, it ends up being messy. You get a lot of questions. Oh, what am I supposed to do next? I forgot what the next step is from your staff. It's inefficient, or your doctors will be afraid to, associate doctors, if you're a business owner, associate doctors will be afraid to jump in because they're just not sure what the next step is supposed to be. And, they don't want to look silly in front of the patient, or they don't want to waste their time, or they don't think it's going to become or be as valuable as just seeing a routine eye exam, for example. So let's talk about some of the protocols. I really want to just give you some ideas, some things to keep in mind as you're starting to build this myopia practice. First of all, standardizing these protocols, as I said, it reduces the barrier to entry, it improves efficiencies, removes the guesswork, but it still allows for that independent decision making for the doctors who are getting into it. So here's some of the things you want to leave your doctors with so they understand how to make certain decisions. Number one, that going back to how do we define myopia, I want my doctors to know I'm not simply saying myo, end of story. I want to write down the age of onset. How fast is it progressing? What was the first refraction? What is the refraction now? What is the change in axial length? What is the family history? All these things are going to inform us in our decision making. So the doctors, you out there, my associate doctors in my office, they need to make sure they're documenting all these things. And we need to, in our EMR, have a place to document as many of these things as we can. And then, maybe to make it easier for associate doctors, help them, give them, like I was just showing you, as far as the 4 treatment options. What's your go-to, maybe a default treatment option that is easy for them to lower the barrier to entry? And providing case examples is always a great idea. So they have some ideas of how to approach certain cases. For staff, we need to standardize protocols as well, right? So my staff needs to know if I'm prescribing X, they need to do Y. If I'm prescribing A, they need to do B. For example, if I have just made a decision in the exam room with the parent that atropine is the right way to go for this patient, I will print the atropine prescription. It prints out at the front desk. My staff will take that paper. They'll say, oh, Harbir prescribed atropine. I know what's next. The staff needs to pull a list of compounding pharmacies in the area. I mentioned that earlier. We need a sterile compounding pharmacy for atropine. We have a printed out list. The staff will put that with the actual atropine prescription. And that way, when I come out to the front desk, it's ready to go. And I'll say, here's a list of 5 or 6 pharmacies within maybe a 5 or 10 minute drive from here. That will make your life easier. In fact, here's one that'll even ship it to your door. Okay. What if we're doing MyoSmart glasses, spectacle lenses? Well, that prescription will be printed out the same way. The staff at the front desk will see it, hand it to the optician. The optician already knows now what the next conversation is going to be. They're prepared for this. So now I bring the patient out to the front, hand over to the optician, and the optician's got the sample lens ready so they can show the patient and the parent, here's what the lens looks like. Here's an image of, some diagrams of how the lens works. So I don't have to do that in the exam room. I don't have to spend as much time doing that. If I'm doing ortho K, I'll bring the patient up to the front and tell the staff, we're going to do ortho K. Good. They already know what the next step is. They need to take the patient into the pretest room, do a composite topography, which is a topography that takes, it's like 5 images in the different zones to make sure I got a nice wide topographical image of the cornea. And they know how to upload and send that off to the lab, and the lenses are ordered. So these things are all important, and the staff need to know where to document things, to sign the consent form before the patient leaves, all these things. Okay. These are all standardized protocols that need to be written down. I am still working on it, right? So my staff will still come up to me like, Harbir, you still haven't created this type of eye exam. Or, well, thankfully that part's done now, but they'll come and tell me, you need to do this still, or we need to streamline this part of the process. They'll make this part easier. And so it's always moving. It's always growing. Your protocols are never set in stone. You're going to change things and streamline things, but it's important to have something documented. So you at least know generally what step 1, 2, 3 is going to be. If you're watching, ask yourself, what is this person? If you're listening, I'll explain in just a second. This is an AI generated image of a myopia champion. I said, create me an image of a myopia champion. And this is what it did. Not bad. It's a lady wearing glasses and wearing a superhero type suit with a cape. In one hand, holding a sheet that says myopia management, and it's got a graph on it. And on the other hand, a little creepily holding an eyeball with the extraocular muscles attached. But the question often comes is, do we need a myopia champion in our office? And honestly, if you have the capacity, if you have one, excellent. But do you need one? No. I think in bigger practices, it's probably more valuable to have that one go-to person that once you say this person needs any sort of myopia management treatment options, you just hand them straight to that one person. Or you don't even have to help diagnose. The doctor doesn't even have to diagnose. Maybe you have enough trust in this myopia champion that they can help, not diagnose, but choose the right treatment option. The doctor will diagnose, but then hand them over to the myopia champion, and they will help come up with the treatment option that's most appropriate for that patient. So that person could be there. We do not have a myopia champion in our office. As I mentioned, we've just cross-trained or trained our staff accordingly so that I know, or the doctor knows when they come out of the exam room, who to hand off the patient to so the next steps could be done. So myopia champion can be helpful, but not necessary. Now, with part of the training and the protocols, you need to have some kind of scripts written down. This is one of the things our staff have come to us recently, kind of like, we kind of stumble on our words when we're trying to talk about that intake form. What is a myopia screening exam? So have a script. It doesn't have to be right in front of them, but just something that they have a little bit of a talk track in their mind. So they know what to say at the check-in desk. They know what to say during the pre-test. They know to mention about billing to insurance and these types of things. The same goes with our doctors. Giving the doctor some sort of a script to have that conversation in the exam room can really, again, lower the barrier to entry, but also really help improve the uptake of the myopia management program. One of the things that happens is associate doctors, quite commonly, any owners who are listening, one of the most common things for any owner is like, man, how do I get my associate doctors to get better uptake or to just even lean into any specialty? Often it's the owner who's doing most of the myopia management or most of the dry eye. But if you can bring in an associate doctor or train up your associate doctors to really lean into the specialty, it's a huge win for everybody. The owner, the doctors, really helping doctors broaden their scope and provide more kind of clinical fulfillment, I think, is what happens when you really lean into specialty care. So lowering the bar to entry for any of these specialty options is really an important thing to do. And providing scripts and talk tracks like this can be super helpful. So, some of the things, for example, I'll say to ask my doctors to kind of try to use these phrases. It's not just about correcting vision today. It's about improving the outcomes in the future. It's not just about refractive error. It's about ocular disease. It's about helping your child to be healthier when they're 40, 50, 60 years old. And which parent wouldn't want to do that? Every parent wants to do that. I provide my silver and gold. I'm giving you my little insights here. I call it my silver and gold statements that I have when I talk to parents about myopia management. The silver statement is, when we were kids, Most parents right now are kind of around the same age as me, but you could, even if you're a younger doctor listening to this and you're talking to somebody who's 10, 20 years older than you could still say it. If you're listening to this and you're an optometrist, you've got to be at least in your mid to late 20s at the at the youngest. And even then, so if you rewind the clock 20 years, there were none of these myopia management options available. So you could still say, when I was a kid, when we were kids, there were none of these options available. So every time I went to get my eyes checked, I got new glasses, stronger glasses, stronger glasses. And if the parent is nearsighted as well, they will easily connect with that, easily resonate with that, and they'll say, yeah, that used to suck. But guess what? We don't have to do that now. We have treatment options that will help us slow this down. And you'll see the parents really leaning in and starting to understand where you're coming from. That's my silver. The gold. Now, the gold is saying, if this was my child, here's what I would do. Now, that one sounds a little manipulative, but if you're really coming from a good place, it's not manipulative. And to be honest with you, most parents will end up asking you that question anyway, especially with me knowing I have kids. I have this relationship and rapport with my patients and their parents already. They know I have kids. So they're going to say, well, what would you do with your daughter? If this was your girl, what would you do? I have 3 girls. That's why they would ask that question. But I just go ahead and say it. Like, if this was one of my girls, I would do this. You know, knowing that she plays sports, or knowing that she's in gymnastics, or knowing that she loves to read and she is not active. Knowing all of those things, this is what I would suggest. And that makes that connection. That parent understands you're coming from a place of really understanding the child and what the child needs. And I will say that usually is the last step to the parent kind of committing to that treatment option. They might still want to take some time to think about it, and that's perfectly fine as well. One of the last things I say to all my associate doctors is to make sure you don't take it personally if someone doesn't want to do it right now. Right now. Okay, they don't want to do it yet is usually, it's not that they never want to do it. They just don't want to do it yet. Don't take it personally. Don't let that deflate you or discourage you. Almost always that same parent will come back at some point down the road. I have multiple parents who are like, oh yeah, ortho-K sounds like an amazing option. But we're just not going to do it right now. Okay, all good. Or myopia management in general. Yeah, my child should do this, but I'm going to think about it. And you think in your mind, like, oh my gosh, like I put everything in front of you. It should be an obvious decision for you to do something. But it's okay. We cannot change a person's mind. We can simply provide them with the best information. And if they don't want to make that call right now, all good. We just say, okay, we don't want to move forward with myopia management right now. No problem. I'm going to see you back in a year. But if you would like to do myopia management, here's what I would recommend. We're going to see your child every 3 months because this is moving pretty quickly. The rest is up to you. Okay. We don't need to beat around the bush. We don't need to, get upset if somebody doesn't take our suggestion and run with it. Just give them the information and let's go from there. Training, of course, is extremely valuable. And one thing for us, if you've got all these documents and scripts and all these things, you need to be able to teach people how to use them, right? You can't just say, here's the protocols. See you later. No. So we hold regular meetings in general. We have weekly meetings. On here, I wrote myopia meeting once a month. We don't do it quite that often. I would say maybe every 6 to 8 weeks. We have a meeting that's focused specifically on myopia management. So making sure, how are we doing with the protocols? How are we doing with the intake sheets? Is there anything that's missing? Sometimes stuff will come up in our weekly meetings because I ask every week, I'll ask, okay, any pain points right now? Any ongoing challenges that need to be addressed ASAP? Then we'll talk about those. But if it's not an immediate problem, it'll just come up during our myopia management meeting because we'll go through all the steps. So this is something that you want to make sure you start to really implement, is these regular meetings. As part of meetings and all of this, communication is so important. Communication with your staff, with your associate doctors or your colleagues, but obviously, of course, communication with your patients, the parents, but also with other professionals, right? Are there referring professionals, GPs, pediatricians, people like that you need to stay in touch with? And documentation becomes extremely important as you go through building this program. I don't want this to seem overwhelming. These are all small pieces that you will build over time. And one thing that helps is having a great EMR. We upgraded from kind of a really basic EMR that didn't help us support in a lot of these ways to a really, really great, robust EMR. We use one called Optisys. I don't know if it's available in the US, but in Canada, it certainly is. And Optisys helps us do a lot of these things. So, we want to write referral letters. We want to write letters to referring doctors to update them. Other things we want to do is provide reports, progression reports to parents. And I'm going to show you that in a moment. But your EMR is going to help you really streamline these things. If your EMR lets you create templates, for example. So I have a template for referrals to outgoing referrals to, specialists. I have templates for letters to referring doctors to say, thank you. Here's what's up with your patient right now. And so on. We have all of those templates made. And so it really takes me, honestly, maybe 3 minutes to write a referral or a letter updating the doctor who referred their patient. So reports that we'll provide to parents, this becomes really important. Parents of young kids are used to taking their children to like a pediatrician and seeing these growth charts. Where's my child on the weight or the height chart? This percentile, that percentile. They're used to seeing things like this. So it actually really kind of lines up with what they've seen for their child if they have a 6 or 7 or 8-year-old child, they've seen this stuff recently. So it's not like out of left field for them to see a chart like this. So it's nice to print something out. What I'm showing you here is from the Maya, which is a TopCon device, which is what we have in one of our offices. And, it shows these nice axial length trends. We can print out on the right-hand side. That's what the printout looks like for the parent. You can put your logo at the top. So, nice kind of visuals, and you can write some notes at the bottom. Your child is progressing at this rate. Current treatment plan is this, and so on. So they can take that home, or you can email it to them. Back to utilizing the EMR, I think, again, just a valuable thing I want to recommend to you. If you don't have a really strong EMR, that should be one of the, after, you talk about buying a biometer and all these other things, that's another investment that you probably want to look into. Okay, let's do a quick recap again. We went through the patient journey. We talked about investment. We talked about the different treatment options. We talked about developing protocols and scripts and things like that for your staff and doctors. And step 5, we talked about documentation and communication, sending reports and things like that. So we're getting close to the end here. I know you're going to get 1 hour of CE credit, but you're going to have to commit a little bit more than 1 hour to me here to make sure I can get through everything with you. But step 6 is really understanding your fees, your cost, your metrics, understanding the dollars and cents. If you are just blindly doing this, you will not make money. You'll probably lose money, and then you won't be able to continue doing this. When I talk about the importance of setting your fees, it's not so we're gouging people. It's not so we're not just worried about lining our pockets. The only way you can provide great service is if you're being compensated appropriately. And, imagine this, you're in the exam room and you haven't yet set your fees appropriately. And you know that you're sitting in there, you're saying, man, I spend so much time doing this. I lose money on this. Or I would make more money if I just saw a regular adult patient and sold a regular pair of glasses. You're sitting in the exam room thinking this. Are you going to provide the absolute best care? Are you going to go above and beyond? Chances are no, right? So if we charge accordingly, we set our fees accordingly, you make sure you're compensated, everything's covered. Then when you're in there and you don't have to think about those external things. You're just one-on-one with the patient. You're just dialed in and you're providing the best care. You're thinking about the best solutions for this person in front of you, which is what we should be doing as practitioners, as healthcare providers. So it is very important for us to set these fees accordingly. And you can't set your fees if you don't know what your cost is, right? Let's say, think about your service as a product almost. If you have a frame on the board and you know that frame costs you $200, you got to sell it for more than $200 if you're going to make some money, right? Very, very simple business math. But we don't often think about what is the cost of the chair, the exam chair that the patient is sitting in. What does it cost you to turn the lights on, to pay the bills, to pay your staff, to just open the doors so a patient can come and sit in that chair? What does that cost? So we need to calculate our chair costs. It's not that complicated. We just go through, I just did it monthly, so I'll go through all my bills for the month. We're not talking about selling glasses and contact lenses because those are, you're buying it and selling it, you're buying it, selling it. We're talking about our fixed cost every month. So what does it cost? What is your rent? What does it cost for electricity, for water, or whatever utilities you have, phone lines, internet, your staff, whatever other costs you can think of that, the equipment that you have, whatever technology you're using in your routine eye exams, add all of that in, add it up. What are your bills for the month? And then you divide that number by, there's different ways you can look at it. Cost per eye exam, or you could look at cost per chair hour. So what you do is for the month, how many exam slots do you have? Let's say routine eye exam, let's say the 30-minute exam slots. How many 30-minute routine eye exam slots do you have in a month? Or you could break it down to a week if you want, however it's easier for you. And then you'll assign a number. You take that big number, all your costs, and divide it by the number of exam slots you have. Now you know your cost per exam slot. That is what it costs you when a patient is sitting in that chair. I like to do it per hour or, per 30 minutes or whatever, but either way, you know, the amount of time you're spending is how much it costs you to have that patient sitting there for that long. And then you can start to figure out how much to charge or what your revenue per patient should be. So on this slide, I kind of show industry average is a pretty broad average for chair costs. It's somewhere in that $300 to $500 range per exam slot, or excuse me, per hour. That's the per hour number. So per half hour or per exam slot, it'll be half of that, somewhere in that, $200 to $300, 200 to 250 sort of per 30 minutes. So really, really important number to think about. If you have a child who's doing myopia management and it requires, in a year, it requires an hour of your time to see them for their routine eye exam, for their consultation, for their myopia follow-ups. That's an hour of chair time. Now you have to think about, well, that's costing me $300, $400. That's my cost to see that patient. So what do I need to charge to not only make my money back, but actually make this profitable for my business? So you're going to start to charge accordingly, right? So we can also, the other thing you could look at is, what is my just average revenue per patient? If I had a routine exam and I had an adult who then bought a pair of glasses afterwards, revenue per patient, maybe it's $300, $400, $500. So now you also can compare your myopia to that, right? If that 30-minute exam made me $500, well, 30 minutes with a myopia patient should make me $500 at least, right? Otherwise, you may as well just keep seeing routine patients. So these are important things you really want to consider when you're setting your fees. So I'd sort of try to break it down a little bit more on this slide here. $300 cost per hour. It's $150 for 30 minutes or $75 per 15-minute segment. So, just thinking about how to start to charge accordingly. And so we do that. We do per visit. So this is what I want to talk about. Some clinics will charge a global fee, a 1-year global fee. So upfront, one large number, you pay that upfront, and then all your fees, no matter how many, they're all covered. Some clinics will do a per visit or per service fee, and there's no right way or wrong way. You really have to find what is right for you. We've actually tried a few of these things. We started with the annual fee and we went to our per visit fee. And I've talked to other doctors who are really, their clinics are really heavily into myopia management. And they said the same thing. I was expecting them to come and say, oh no, Harbier, this is the right way to do it. But every clinic I talk to has a different approach. So you just have to find what is right for you. So, pros and cons. The one upfront fee is very simple. There's here's your fee. There's nothing else. It's clean. It's simple. There's no patient doesn't feel like you're trying to add a bunch of fees in just to get more money from them. But the problem is it's usually a big number, and parents are often got a little bit of sticker shock and are not as open to paying that, whatever that number might be, $500, $800, or $1,000, whatever your number might be. They're not always so comfortable paying that. So we found the per visit fee has been a little easier for us. We keep it really clean. The other thing, the reason that per visit fee has been working well for us is because our doctors would say, I feel weird charging this much money, but I'm only seeing the patient once or twice a year versus charging the same amount of money and seeing the patient 4, 5, 6 times a year. So we thought maybe it makes sense to do it per visit. And our doctors felt a bit more comfortable. The number is smaller. It's a bit easier for the patient to understand, okay, you're going to pay this each time you come in, but it's a smaller number. So that number has to account for, again, our chair cost and make sure that we're not just breaking even, but we're actually making money the same way we would at least when we see a routine eye exam. So that's the way we approach it. And we've found lately that's been working well for our practice. Some clinics will do a per service. So they really break it down. So we're charging you this much for refraction, this much for axial length, this much for images. And that works in some cases, but in other cases, patients feel a little bit like, man, you just keep adding line items to my invoice here. So we just do that one fee per visit. And then whatever the doctor needs to do, whether it's axial length or retinal images or whatever, it's just all in that. Okay. Getting close to the last two things. We're not going to spend as much time on these last two topics, but I do want to just mention how important these last two topics are. The step 7 here is really thinking about your marketing. And there's different ways of marketing, as we know, right? There's your sort of traditional marketing, there's internal marketing, and of course there's outward facing, digital marketing and things like that. But the first place I think is the most important to start is your referral network. Building your referral network is what's going to help any specialty really grow. And so what does this mean? It means telling anybody right? Your referral network is your family, your friends, your kid's soccer team. This is all part of your referral network. Your referral network is other professionals, GPs, other ODs, pediatricians, talking to all of these professionals and letting them know you offer this specialty care and why it's so important. So, on this note, what we did is that brochure I showed you earlier, we made another one that's very similar, but it's geared towards to ODs. And so on it, it says, we'd love to work with you. We want to support our colleagues. If you're not into myopia management, we love doing it. We will see your patient for the ortho K or the whatever, and then we'll send them right back to you. And just letting them know what equipment we have, what technology we have, what services we provide. And so I had my staff take that with some cupcakes and hand them out to a bunch of ODs in our area. Similar thing with GPs, hand out brochures, talk to their staff, let them know that you offer these services, that they don't need to be referred to. In Canada, a lot of times in BC, these patients will get referred to an ophthalmologist, and that's just not necessary. An ophthalmologist doesn't need to see a child who's just a little bit nearsighted or even very nearsighted, to be honest. That is not what I think ophthalmology is needed for. Ophthalmology is needed for the more advanced stuff, the things that really need to be triaged, and the more advanced ocular disease and strabismus or whatever else you think that falls under their purview. But myopia, that's an optometry thing, right? Like we should be taking care of that. And we should educate our fellow professionals that these patients should come to an optometrist and can be well taken care of because we have all of this technology and we offer all of these services. So build that referral network. Then let's get into the traditional marketing. Talk to newspapers and your schools. Again, that's part of your network. Do the mail outs and things like that. Just let your local community know. Tell your friends that you do this. I think the old school marketing is coming back. Maybe not so much TV and radio, but old school, traditional, boots on the ground marketing, I think, is really making a comeback because digital marketing is still very, very valuable, but the space is getting a bit more crowded and people are getting bombarded with online ads left, right, and center. They ignore most of it, right? Think about when you're scrolling through Instagram or TikTok or whatever, or the ad that comes up on YouTube before the video you actually want to watch, just skip, right? So getting in front of them in a more traditional way is actually becoming valuable again. And of course, digital marketing. Social media is huge, though. Don't get me wrong. You want to be, if we go right back to the very, very beginning of this lecture, the patient journey starts when they're looking for you online. You want to be found. You want to be able to be found. And you want, when you're found, to be able to show the information that's relevant to the person who's looking for you, right? So share information about doing myopia management. Share some patient stories. Ask your patients if you can take pictures or, success stories of ortho K and all these things, and share that information. Make sure it's on your website. Make sure people are, your website's coming up, usual SEO stuff. Write lots of blogs. I think blogs are back and they're legitimately a thing again, and I've been just using ChatGPT to type up a bunch of blogs, and you got to refine them. Of course, you can't just say copy paste, but I'll go to ChatGPT and I'll write a nice long description of what I want. I love using the voice command with ChatGPT because then you just talk. You just say, hey, ChatGPT, I'm looking to write a blog about myopia management. Actually, I'm looking to write a series of blogs. Maybe help me outline a series of blogs that I could write on myopia management, starting with the basics, a blog on what is myopia management. Then let's do one on why is axial length important? What are the risk factors? And maybe another one on what is the long-term health risk of myopia progression and so on. Outline a bunch of blogs and then hash them all out and then read them through. Honestly, within an hour, you could have 10 really great polished blogs written, upload them weekly or monthly or however often you want. Now you got lots of content on your website, and that's going to help improve your search results. So again, not to overwhelm, but there are lots of things we want to keep in mind, slowly implementing all these things. All right, the last step, step 8, is making sure we're building these industry relationships. There's so much value that your reps will provide you, whether it's your contact lens rep, if you do ortho K, your rep at the lab there, if it's your frame rep, your lens rep, whatever, whoever it might be. They have so much insight. They know more about their product than anybody else. So if you have troubleshooting issues or you need, help with solving a problem for a patient, your rep is going to be the person to talk to. If you want to learn about what's been successful for other people, they have these insights. They're popping into dozens, if not hundreds of offices, and they're seeing what works well, what looks good, what doesn't work. And you can glean all of this information from your rep. They're always going to be happy to share. And they're great with staff training. Our reps come in, we do these weekly meetings. Once every couple of months, we have a rep come in from this company to teach us about the different lens options for ophthalmic lenses, or, contact lens rep comes in, helps us maybe with sales training, things like that. But They have all the knowledge, they have all the ability, they have training programs that have been developed by the companies that are really valuable to us. So really, really lean on your reps, get their phone number, text them, email them. They will love it because if you win, they win, right? Their interest is making sure your business is successful because then their business will be successful. I like to end with this. I always used to say, I say that I always used to hide from my reps, but now I hug my reps. I literally, a rep would come in, I would say, close the door, tell my staff I'm busy, I don't want to talk to them, just take some notes. But now when my reps come in, I actually walk out front and I'll give them a big hug. Most of them, the ones that I know well, this is Kathy, who's our Hoya rep, and she's amazing. So I always say, really lean on your reps. You don't have to hug them. You can shake their hand, but really lean on them. Take their knowledge, take their information. It's really going to help your business too a lot better. And if you're not the business owner, you're the associate doctor, I still recommend getting out there, meeting with reps. Reps want to sit with associate doctors as well. And you can learn so much information. It'll help you get better clinically and maybe help generate more revenue for yourself as well. Okay, quick recap. Out of all of these things, the 3 key things I want you to take away, but obviously all 8 are important. Number 1 is go through the patient journey, optimize that, understand every step of the way and where you can implement something related to myopia management so it becomes just part of integrated. It's just part of your practice every step of the way. Build the protocols. So when you pull one lever, all these things will happen. Your staff knows what happens next. Your doctors know what happens next. Everything is more streamlined. And then the last really big thing is understanding your costs and your fees, because again, if we don't do that right, you're going to lose money. You're not going to be interested. You're never going to lean into it. You're never going to find the success and the fulfillment from this unless you know that you're going to make money from it and it's going to be fulfilling both for your practice financially and for you clinically and personally as well. All right, guys, we did it. We got to the end of this. I know it's a little longer than an hour, but don't forget, you are getting credit for this. You will get credit. If you are looking for CE credit right now, after you're done with this, I want you to go click on the link in the show notes. That's going to take you to NECO's website. Go look for this webinar. Make sure you have to register and then click that you did this. You got to take the little quiz. You got to pass the quiz. You got to get 70%. Pass the quiz and then it's going to be easy. Don't worry. It's not a hard test. If you listen to this, if you took away the key points, you will pass the quiz and then NECO will email you your certificate. And there you go. Bada bing, bada boom. You got yourself 1 hour of CE. So thank you guys. Man, this has been incredible. I can't believe we're finally doing this. I'm really grateful to my alma mater, NECO, and Dr. Gary Chu at NECO there for supporting this, for helping me create the very first COPE-approved episode of the 2020 podcast. I hope you enjoyed this. I hope you found this lecture valuable. I hope that there's something that you could take from this that you feel like you can implement in your practice, in your business, in your clinic, and go get that CE credit. Click the link in the notes. And once again, thank you. And let your friends know. If anybody out there is looking for CE credit, looking for an easy way to get some CE, link them this episode. Tell them just listen to it, then click the link and go get your CE. But thank you again for all the support. Even if you're just a regular listener who's not looking to get CE today, thank you so much for all the support. Thank you to everybody once again for listening to the 2020 podcast, Canada's #1 optometry podcast. I'll see you guys in the next episode.